presentations lined up for today. I'm going to turn it over to Joel, who's going to do the introductions.
Okay, thanks, Usman. Yeah, this is going to be a great session, and welcome everybody. So we're going to hear about some exciting work involving therapeutics, a study of therapeutics using N3C, and this has been interestingly, it's been well over a year, and various things are now being renewed. We've got 2.6, almost 2.7 million records of COVID positive cases, 7.9 million people. So the database continues to grow. Next slide. So I think without further ado, we're going to kick off the talk on therapeutics using N3C. And so Hopkins folks sharing their screen, I gather.
I'm sharing my screen.
Great. Okay. Well, hit it. We see your screen. Very nice.
Okay, perfect. Hello, everyone. Thank you for this opportunity to present our team's work at N3C Community Forum. Dr. G. Caleb Alexander and I co-lead the N3C pharmacoepidemiology team. And on behalf of our team, I'll present today challenges and opportunities studying therapeutics using N3C. So our team is focusing to generate new knowledge regarding the real-world use, safety, and effectiveness of therapeutics among individuals diagnosed with COVID-19. We use high-quality observational studies on therapeutics of high importance, and our goal is to generate knowledge and evidence that can improve the use and clinical value of treatment among those diagnosed with COVID-19, and it can inform clinical practice. We have almost 15 projects in our team. Some are completed, some are under review, and some are in analysis stage. So today I'll present three topics which are completed. So the first one, we wanted to understand how drugs are used among patients diagnosed with COVID-19. So we know that scientific community has made major investment to repurpose existing drugs, as well as to develop new therapies to prevent and treat COVID-19. In particular, three drugs received significant attention: hydroxychloroquine, remdesivir, and dexamethasone. So we conducted this study to understand how these drugs are used at national level over time, and how drug use varies across health systems. So for this, we used N3C data and characterized drug use over time and variation across health systems. And I'll show just one result and conclusion. So the figure on the left shows how drug use has changed over time. The green color denotes hydroxychloroquine. And as you can see that earlier in the pandemic, the use increased quite a bit, reaching almost 45%. And suddenly, when FDA issued caution and revoked emergency use authorization of hydroxychloroquine, and there were other studies on safety associated with hydroxychloroquine, altogether led to a significant decline in hydroxychloroquine drug use. The other two drugs, remdesivir, which is purple color, and dexamethasone, which is orange color, as you can see that the use started increasing after May or in early June. And it's primarily due to results from big trials, which led to adoption of these two drugs. And overall, the use varied substantially across health systems. So for remdesivir and dexamethasone, we evaluated the use across 43 health systems in the N3C. And the variation was huge, and it could be due to patient case mix, drug access, treatment protocols, and quality of care. And one important point I would like to make about dexamethasone, so we limited our cohort to patients who were mechanically ventilated to see if they were receiving dexamethasone or not, because that's the indication for dexamethasone. And we found using N3C that 1 out of 5 patients who were potentially eligible for receiving dexamethasone and who might have benefited from this treatment did not receive dexamethasone. So this second study is led by diabetes team, and we collaborated with them. As we all know that diabetes is strongly associated with higher risk of COVID-19, and in particular, 2 classes of medication, GLP-1 agonist and SGLT2 inhibitors. They were showing some mechanism, plausible mechanism, which can help reduce severity of COVID-19. So in this study, Anna and her team compared pre-morbid use of GLP-1 and SGLT2 with COVID-19 outcomes. So here, figure on the left shows forest plot where you can see the comparison of GLP-1 versus DPP4 inhibitors for different COVID outcomes, mortality, emergency room visit, hospitalization, mechanical ventilation. And the figure which is denoted with B that compares SGLT2 inhibitors versus DPP4 inhibitors for these outcomes. And this observational cohort study found that among patients diagnosed with COVID-19, pre-morbid GLP-1 and SGLT2 inhibitor use was associated with lower odds of mortality and other adverse outcomes. So this is the third study I would like to highlight. We know that there's mixed evidence regarding the impact of immunosuppression and immunosuppressive medication on COVID outcomes. And it's all further unclear whether this association vary by medication class. So Katie Anderson, she's a PhD student, is leading this project. She did a small study using Hopkins data and found some preliminary findings. And then we extended this study with N3C data. And it's a big cohort, so it allowed us to compare individual drug class. And in this study, we compared 15 pharmacological classes. And here, you can see that with the exception of rituximab, which is a blue color line on the forest plot, all the other immunosuppressive drugs, which included rheumatic medication, antineoplastic medication, and anti-metabolite therapies, we did not find the association of these drugs with bad COVID outcomes. So there was no increased risk of ventilation or death for in immunosuppressive medication. And these results are important for scientific community and clinicians because these products are commonly used to treat immunosuppressive conditions. And there are ongoing questions regarding the degree to which this medication increase or decrease the risk of COVID-19 outcomes. So I have highlighted only 3 studies here, but we have other 12 ongoing studies which are in different phases of in our pipeline. You can see all those studies in our pharmacoepidemiology domain team, and all the projects are, if you are affiliated with N3C, you should be able to see our team folder and access everything. So challenges, while doing these studies, what challenges did we face? So we face usual challenges we face in pharmacoepi, because it's not a clinical trial and patients receive drug A versus drug B. because of certain reasons, and how do we control for those reasons? How do we control for selection bias and confounding while making fair comparison between drug A and drug B? And we think a lot about this thing. And mainly we do it in two different ways. One, we try to control confounding and selection bias at design stage. So we try to make our population as homogeneous as possible. We try to have inclusion and exclusion criteria such that it reduces confounding and selection bias. And there would be few things which we can do at a design stage. We try to control them using state-of-the-art analytical techniques such as propensity score and other methods. With regards to N3C, I will discuss three challenges. The first one deals with exposure. So one issue we faced with N3C is dose information is largely missing. And this is important in some of our studies. So for example, in immunosuppressive work, we really wanted to know dose of glucocorticoids. And due to the missingness, we couldn't do that. And we acknowledge that in the limitation, but that's one challenge we faced. The other challenges deals with more technical issues. Like for the immunosuppression work, we had over 300 drugs we wanted to identify. And we had to break down those 300 drugs into different chunks because searching all those drugs at once in enclave was overloading the server. And also we had to deal with some data quality concerns coming from different sites. And we got some great help from N3C to figure out what to include and what not to include. The second challenge is with respect to outcome. So in N3C, we do not have information about advanced directives, like do not resuscitate or do not intubate. And this could influence how we ascertain our outcomes. And second, we also do not have information about COVID severity, for example, high flow nasal cannula or oxygen flow. And we learned from N3C that this information is recorded in flow sheets, which is not a part of OMOP, and that's why we were not able to get this information. And then we had few patients with funky numbers, like someone who was in hospital for 400 plus days. We also had some patient with not plausible BMI values, but we got some great help from our team and from other teams in N3C, and we were able to solve these challenges. And the final challenges with respect to covariate. So we had missing data on some key clinical characteristics, and it's not just with N3C. I guess we see this with several other electronic health records data, and we know how to deal with it. But in particular, we had a lot of missing values for body mass index. We did multiple imputation and some other ways to handle this missingness. We also saw missing values on labs and vital signs. The other challenge, we had almost 1/3 of patients who came to this health system for the first time. So we do not have the baseline health information. So for example, this table shows that we have around 137,000 patients, which were used in utilization paper, which was published in Annals. For 93,000 patients, we had the baseline information as well as the hospital information. And what we did is we tried to characterize a comorbidity score using just hospital information and using hospital information and previous 1 year baseline information. And as you can see that the comorbidity score for this patient is 1.9 using just hospital information versus 2.9 when we used more data, which came from the baseline records. But for the 1/3 of patients where we did not have baseline information, the comorbidity score is 1.3. So I think we definitely underestimated comorbidity burden for this patient, but there was no way to know by what extent. And again, we acknowledge that as a limitation, but this is something we faced while doing our analysis. And then we had some practical challenges like learning. Palantir was new to many of us. In pharmacotherapy, we were used to doing analysis with SAS, and we had to learn Python or Spark or find a team where they know how to use these languages to do some of the analysis. Also, some of us had a big learning curve in creating and using concepts for exposure, outcome, and covariates. But despite all these limitations, the N3C provides the largest repository of individuals with COVID-19 in the US. And it's a great resource to study how drugs are used in the US and compare the safety effectiveness of these medications for COVID-19. We have several ongoing projects. I'll mention two. One is focusing on anticoagulants, and the other one, which is focused on methods. And I guess the second presentation will cover some of these methods work. We continue to evaluate how drugs are used for the treatment of COVID-19. And we are always open to new research ideas. If you're interested in studying drugs in COVID, feel free to join our team. Feel free to reach out to me or Caleb. And here is the link. You can learn more about our domain team. And so we have over 50 plus team members from 16 different teams. And finally, we would like to sincerely thank N3C for making this resource available to us. I know it's not easy to create such a nice resource in a very short span of time. And we are truly standing on the shoulders of giants to conduct this meaningful research work, which can inform clinical practice and policy decisions. With that, I'll say thank you, and I'm happy to take any questions or comments.
Okay, so there is a question from Mara Imperanto, which I think was a really good question. First time encounter for quote, first time encounter with health system. How is the health system defined? For instance, could the patient EMER be located in a primary care facility, facilities, local EHR system? So the way we define health systems, so N3C, they bring in data from different health systems. So for example, like Johns Hopkins Health System, we have 5 different hospitals within Johns Hopkins Health System, but it's considered as one system. So if someone was in Johns Hopkins Health System, which means like one of those 5 hospitals, then we would consider them as repeat admission if they were previously coming to Hopkins. But if they came for the very first time, then we would consider that as a first time encounter. And operationally, we define as like you were hospitalized on May 25th. Do we have any record for that patient in N3C 1 year prior to May 25th? If not, it means we assume it's first encounter in the N3C or in the health system. Okay. I see the second question, how did you impute BMI? So we used our package, I can't recall, but we made some assumption like missingness, not at random. And that's how we imputed BMI, but we took help from other group informaticians. They did a really nice job showing height, weight, and consolidating that information, and finally recommending us how to do imputation for BMI. And I'm happy to share more information about that, like exactly how we did it in N3C Enclave. So Harold asked a key question. So you've obviously learned a tremendous amount and developed a lot of great methodology. Did your team supply any code workbooks, templates to the knowledge store?
For BMI, actually, we used information from knowledge store, and for drugs, I think in one slide I showed how we identified drugs, and we used that logic to identify drugs, but we did not develop concept for each drug separately. But all these codes are in our pharmacoepi enclave team, and anyone can access it, or we are happy to share if you cannot access it.
Okay, it says, so there's going to be an answer to this question live. Is that doable?
Sorry, which question, John?
There was just, there was a, I didn't actually catch the name. Oh, okay, no, I'm sorry, I misparsed it. So I think this goes beyond just BMI. I mean, I think the question, which is I thought a good question, you know, of the work you've done, have you been in a position to supply any code based on sort of any of the analyses you've done to the knowledge store, so other teams could use it? If not, that's fine. We're just yeah. I think people are interested in your work, so if there's
sure,
to capture it that way.
I'm just thinking like I mean, we are happy to provide, everything is accessible and we are happy to share. It's just like what information we can share or what information is useful to people. Because I think for the hospitalization, we used information from knowledge store. For BMI, we used information from knowledge store. For drugs, we created this template, how we can identify drugs. And we did some methods work where we used OMOP concept, we used the string search, we combined both to make sure, are we capturing all the drugs? Which approach is better? And after doing that exercise, we decided to go with this way of identifying drugs.
Okay, no, that's great. And Harold says he'll follow up online. I mean, this is
sure.
Great work. And
thank you.
I think the only thought is just the, you know, can people leverage some of it in their own research? It's great work. Okay, so I think this is a great talk. I really appreciate it. So thank you. So I think we're ready to move on to the next thing.
Hythem, I think Hythem is the lead for that.
Okay.
Yeah, so actually, I'm actually a little bit under the weather and I have a very persistent cough. So my team members are going to be presenting and, you know, they'll do an excellent job. So I apologize for that.
No worries.
We will all attempt to channel Hythem as best as we can, and then he will fix the things that we mess up in the chat window, hopefully. So, this is Michelle Johnson-Funk. I'm at the University of North Carolina in Chapel Hill. And I have to say from the get-go, 98% of the credit for the work you're about to see really goes to Hythem and Andrew. Jess and I have been working with them for a couple of months now to think about these issues and to provide some epidemiologic input into it, but they really have done the heavy lifting. So what we wanted to share with you today was sort of the process of really digging into these data and learning about them in a way that would be rich enough to support the kinds of treatment effectiveness questions that we want to be able to ask. Next slide. So let me start by acknowledging Emily Pfaff, who I think probably is known to many of you and who originally put us in contact, as well as Claire, Soko, Ken, and Maddie, who've been involved in this smaller group. And it's really a sort of an offshoot of the a combination of the pharmacoepi domain team that you heard about earlier from Hemal, and the Datos group. And we joined together to try to think about both the underlying data that we're working with and how to bring those into questions that require a fairly high level of data quality, as well as the methods and study design issues that come out of that. So because the underlying data foundation is sort of primary, we wanted to talk about that today, and then we hope at some point that you'll have us back to talk about the study design and methods issues that are kind of the second stage of this project. Next slide. So all of you, I think, are familiar with N3C to a pretty rich level. This really is a remarkable resource pulled together over an intense period of work. I still sort of marvel at everything that has gone into this. And the whole point of this is to create a resource that we can all learn from to do a better job of tackling the current and future pandemics and other healthcare concerns. But the fundamental nature of these data is they were created for clinical care and billing, but not for research. And in order to go from sort of the clinical context in which they were generated to something that we understand well enough to be able to apply it to research is a real process. There are significant complexities within the data. And then, of course, taking those and doing research with them requires another level of studies design. So on the issue of the complexities in the data, this is where we're going to focus our energy today. And there really is still urgency around these issues. But if we don't understand the data and we sort of churn things out prematurely, we can also do a lot of harm. And there's a lot of access to data out in the world right now. And we really want the quality of that work to be as high as possible. So the objectives overall of this group are to try to kind of lift all boats, to create a set of understandings, approaches to help all the research that goes forward around treatment safety and effectiveness to be as strong as possible. Next slide. So the overview of what we're aiming to do is to use sort of an illustrative example to understand where some of the strengths and limitations are of the data and how different study designs might impact our results, so that we can come up with a strong foundation for treatment comparisons broadly going forward. And this has been ongoing work since May. We're working toward 2 to 3 publications that are in development right now. And the work you'll see today is based on a level 3 limited data set. The figures have been reviewed so that you can see them. We're happy to share. And I think at this point, I'm going to turn it over to Andrew to start telling you about some of the detailed issues we've been investigating.
Hey, great. Thanks, Michelle. So the first thing we're going to talk about is absolute pandemic timing and how that impacts the outcome that we're interested in, which is in-hospital mortality. So COVID, as we all know, has come in a series of waves. And as the hospitals become more crowded, shown with the bars, the chance of any given patient hospitalized with COVID dying goes up. And so this is a really important variable that has to be considered when you are looking at any sort of treatment efficacy or other study that has an output of death. So to deal with this, we're of course using the limited data set. It's hard to imagine doing any sort of study with an outcome of clinical severity using the safe harbor data set, certainly not in hospital mortality. And we are also dropping sites that shift their LDS data by more than 7 days or don't report whether they do shift their LDS data or not. And then we're including pandemic month as a covariate in our analysis. Probably one of the most important covariates. Second issue we want to talk about, and anything to add there, others? Michelle?
Yeah, I was just going to say for clarity that the reason that this timing issue is so important is because the patterns of drug use are so different over time as well. So there's a strong correlation between mortality and the likelihood that you will survive your infection with COVID, along with these temporal changes in which treatments are being used. So if we don't have a handle on that calendar time effect, we're probably not going to get the right answer because these are so strongly correlated.
So the second issue we want to talk about is data missingness. So before that, a little bit of background on why we are so interested in the lab data and its missingness in particular. We actually started this project with the directive to make a sort of very simple dashboard that would allow you to look at the effects of different interventions on COVID outcomes. And the sort of immediate problem that you hit in trying to do something like that is that without controlling for severity of disease, an intervention can appear harmful. So for example, in the recovery trial, we saw that dexamethasone, it has a beneficial hazard ratio in patients receiving oxygen or invasive mechanical ventilation, but actually trends towards harm in unventilated and patients. So it's really important that you're comparing the same state. And so we use a lot of proximal factors like O2 saturation, creatinine, CRP, and other labs, as these actually mediate the effects of the more distal factors like BMI and demographics. And we have some more data on that, which we can get into next time. And this is really a key advantage of working with electronic health records as opposed to claims, because you have this daily lab and vitals data, whereas of course claims doesn't. Anything to add there? Okay.
Oh, that's great.
So this is a hierarchical clustering of the lab missingness by site for a couple of the key vitals, actually: BMI, weight, height, oxygen saturation, respiratory rate, temperature, and heart rate. And so the first thing that you can see is there's a cluster here where the fraction of hospitalized COVID patients having at least one measurement of this type during their visit is near zero for all of them. And this is actually where all of the ACT sites end up. So we end up dropping everything in the ACT data model. In part, this is because their CDM doesn't have a place for vitals, although that is something that's changing as I understand it. And then you can see there are lots of other clusters that contain other data models. And we break it down in a little more detail by data model like this. So here, this data has actually been put on a standard scale. So red is more missing and blue is more present. And we can see here that among the trinetic sites, there's a large cluster where most of the patients have at least one of these measurements, and then another cluster where most of the patients do not. So sort of this cluster will be dropped from the analysis. And then same thing for, oops, it's not quite responding to my, okay, there we go. Same thing for Picornet. One cluster where most of the sites, most of the people at these sites have at least one measurement, and then here's a big cluster of missing data. So the missingness tends to be highly correlated, and you tend to either have a good representation of these labs or not, suggesting that it really does have to do with the ETL process at the individual sites. The other point about missingness that we really wanted to make is that it's time dependent. So you can see, and it varies by site in that time dependence. So here, for example, site 960 increases in missingness of O2 sat up to month 5, and then decreases, and the pattern is, the peak is different at different sites. And then some of them have a low level of missingness across the board. But this time sensitivity is really important. It could correlate with all sorts of things, whether it's a change in EHR technology or perhaps a correlation with occupancy of the hospital, where when they're more busy, they're unable to record data as richly. So in summary, our solutions for working with this are to drop sites with high levels of missingness and to work with sites to improve data completeness. The heat maps that I showed you were sent to all of the sites, and we got some really nice feedback from several of them who are using that information to try to improve their ETL processes. And that data will also be published in an issue of JAMIA on a general data quality paper about N3C. We just learned was accepted today. Okay, anything else on missingness from the?
So I think my take home on missingness is that it's incredibly complex. It's site dependent, it's time dependent, it's spatially dependent, depending on where in the country it's happening. And ultimately, it's very hard to know what the nature of the missingness is unless we are in conversation with the site specifically. And obviously, because of the the de-identified nature of what we are looking at within N3C, we can't interrogate one data point or one site at a time to fully understand what's happening there. But I think this approach that Andrew and others have taken of feeding this information back to all the sites and say, hey, look, we're seeing some significant missing or irregular patterns of data here, is a way to help improve the quality ultimately. And that from a statistical point of view, if we have the data and that's all we can do, we'll do things like multiple imputation and necessarily invoke assumptions that may not be tenable to do that. It's always better to just start out with better data to begin with. And so I think it's really valuable to feed this information back to the sites and for them to know that they really want to contribute to this endeavor and to have meaningful data from their site included. And in order to do that, they might have to go back and push in some additional information that didn't make it through in the first pass.
Okay, great. The next issue we wanted to talk about has some overlap with the first presentation, which is specificity in drug coding. So this is the breakdown of sort of the level at which dexamethasone is coded among the COVID hospitalized cohort that we looked at. And we can see that the most frequent code used is actually for the RX norm ingredient level, which means that we have no information on strength or route, and those are, as separate OMOP fields, are most frequently null. So this is really important to consider if the drug you're using has multiple routes, like some of the steroids, which can be applied topically. And so, one solution that we and others have been looking at is to identify the coding pattern used by sites. And we may be able to drop sites that tend to code only at the ingredient level. Can also give this feedback to sites as we did with missingness. Anything else you would add to that, Michelle? Okay.
Oh, that's great.
All right. Okay, next issue we wanted to cover was drug exposure duration. So we frequently see drug exposures with a start date but no end date. And we also see different strategies for coding the same treatment regimen at different sites. Remdesivir is a good example. We expect it to be a 5 or a 10-day course of treatment. And there are sites where it is recorded as a start date and then 5 days later an end date, or 10 days later an end date. But more commonly, it's recorded as a series of 1-day exposures. And we actually use this to assemble what would be the drug era table normally in OMOP by connecting all of these one-day exposures. And we can, of course, only do that when we have an end date. And making the assumption that the null end date means that it's the same as the start date, you get a distribution that looks like this for remdesivir, where the most common peak is 1 day exposure. You do see a peak at 5 and 10 days, but obviously that's not the majority of cases. So in general, we have been treating this as a binary variable, either exposed or unexposed, and not attempting to do any sort of time varying analysis.
I guess my only comment there is that, you know, if we're interested in just comparing individuals who initiate remdesivir versus initiate, say, some other drug, you know, we probably can sort of make some simplifying assumptions here, and that'll be okay. For some of the treatments that we're interested in, we might want to look at different treatment strategies. So for patients, is it a better treatment strategy to give them 5 days of remdesivir or 10 days of remdesivir? Well, if we don't have the ability really to capture what that exposure looks like over the duration of hospitalization, we probably can't ask that kind of a question.
Okay, next we wanted to cover, and I think this might be the last, death that occurs outside of the hospital and whether we can track that. So one way that we might see this is by looking at the discharge disposition, in particular discharge to hospice, which we do see in the data. However, null and no matching concepts are by far the dominant discharge dispositions in the data, and part of that is because only PCORNet and OMOP support discharge disposition. So the other two models will have nothing there, and OMOP and PCORNet will sometimes have it populated. So essentially, we have stopped using the composite endpoint of mortality in the hospital or hospice and focused only on inpatient mortality. But there are several hopeful efforts that may make this easier in the near future. One of them is PPRL, privacy preserving record linkage to open source death data, which is underway now. And that should provide through linkage to things like obituaries that have been compiled. We may have a better view into deaths that may have been missed by the electronic health record. And then the other possible option there is PPRL linkage to claims data, which we hope to see in the near future of N3C. Okay, I think this is the last one. The variable baseline history that's available for patients coming in with COVID hospitalizations. So if you look at the months of prior history for patients hospitalized with COVID, and I think the first presentation referenced this as well, the most frequent case is actually no history. And then you see sort of an increasing distribution after that. This is obviously important for a lot of reasons. We can see, just as the previous presentations showed with the Charlson comorbidity, we see a lower incidence of all sorts of different comorbidities in the patients that don't have a history. Interestingly, we also see a significantly greater chance of dying from the patients that don't have any history in N3C. This could be that they are particularly severe cases that are transferred from another hospital, a primary hospital, or perhaps this could be a social determinants of health issue where someone doesn't normally have access to care and is coming in because they are very, very sick with COVID. We really don't know in this case. So we also see some variation depending on the types of patients that individual data partners see, what kind of practice they have. And then we see not surprisingly, an increase in the average month of history as the pandemic month goes on, in part because of the N3C collection strategy. Here we have it broken down by month and data partner. And so you can see some data partners increase the amount of history available on average for their patients over time, and others have different patterns. So again, this is a really complicated phenomenon. But our basic plan here has been to remove patients with insufficient history, usually about 6 months or less. And then to be careful with studying the difference between patients with and without history. We hope that when the claims linkage is available, we'll be able to capture much better and richer patient history than what we have in the EHR.
And I'll just jump in to say, this is not a unique N3C challenge. This is something that is sort of a fundamental part of the struggle of using EHR data anywhere. And the linkage to claims data is potentially a really good solution to this. So I'm incredibly hopeful and excited that the linkage to claims that is on the horizon is going to make a huge difference in terms of being able to have a better handle on what, sort of the background health of patients look like before they came in with COVID.
Okay, so to wrap up, we saw data quality issues across all of the domains, whether it's lab values, drug exposures, history, and as well as outcome and mortality. And I think on this team, we're all very interested in characterizing these challenges and making our findings available for the community to help people make the best use of this data. Anything you want to add in conclusion, Michelle?
That's great.
Or Hythem?
You did great, thanks.
Okay.
No, this is fantastic. So thank you. So there are a number of questions on the chat, some of which have been answered and some of which haven't. Maybe Andrew, do you, since you're more than familiar with the chat routine, do you want to parse through this, or would you like me to?
Okay, there's a question about PPPL linkage to the national index. I don't know if or someone else on to discuss.
Yeah, I'm just to answer previous question. All the PPPL data isn't to be linked individual, just similar to what it takes now to use to get a level 3 data access, meaning that you'll have to have a local IRB determination, and you will, just like when you're giving the rationale for using N3C data and what level you want. So if you use the level 3, you say, I need zip because of this, I mean full zip because of this, or I need visit dates because of this. You're going to have to tell the DAC why you need it. You should include the rational, you have to pick the PPRL that you're using, one-to-many, mortality plus CMS plus viral variants, whatever you choose. And for each one of those you choose, you're going to have to tell the DAC why it's necessary in your analysis. It's still, we're not still asking, still less than a page of text. We just want to make the DAC's job is necessary, but minimum data needed to get to where you're doing. So it will be there, but you will need a local letter of determination.
So Ken,
yeah.
So go ahead.
Regarding the National Death Index, we have been working with them on and off. They are a little bit behind the curve. I know they have a lot of demands on them, but the data that comes in, and I've learned this, is that the data comes in from states themselves, and then the CDC aggregates that data and it pays the states for their effort. So the cost on how they do it is based on a per patient basis. And if we were going to price it on that cost, it would be millions of dollars. And so we have been trying to work with them to figure out a better cost model. They have been very interested in the PPRL. However, we still have the problem that the National Death Index is months, if not a year behind. So it would not be particularly helpful in the case of COVID, and which is one of the reasons that we have gone kind of outside the CDC, and we have paid a group of folks to bring in mortality data. The downside is that the date will be there, but the cause will not be there. However, there's a good side to this also, is that we're getting the source it'll be 3 different sources that give us that information. And we'll be putting this up on the website so you'll understand the good, the bad, and the ugly of each source. So you will be able to see, source, we got the source that someone passed away from 1 of 3, 2 of 3, 3 of 3. And you as an investigator will have the ability to say, I'm confident that this person passed away. So we aren't going to make that judgment. We will be making somewhat of a judgment. So if the PPRL said, somebody who was 12 died, but the obituary said they were 90, we're probably going to, red flag that one and say, I don't think you should trust this one because, their date of birth is totally different, or the date of death is months apart. If the date of death is 24 hours apart, then I think we'll let the investigators know, but that's kind of okay because a lot of this is coming from obituary data, and that may not show up in the newspaper until the next day. And so having the date of death being off by 24 or whatever we decide as a community is acceptable is okay. Whatever we decide will be completely transparent. So I hope that answered your question on the NDI, and we're still working on it, but it's an ongoing story.
So Ken, so I was intrigued to see a variant listed under PPRL. Where are we with that?
We've got 9 sites that have been funded or agreed to give us variant data. It's pretty exciting. The variant data, just FYI, we N3C will get just the summary data. The sequence data will go to NCBI because they have an infrastructure to hold sequence data, and we'll be working with, and so if you need to actually see the sequence data, you will be able to do that. I can't tell you when you'll be able to do that because we have to work something called an interconnect agreement between National Library of Medicine and CBI and NCATS, but the idea is there's no reason for NCATS to store sequence data when there's already an enormous infrastructure that exists to do that. So we made the decision that that should continue, though it has the same PPRL on it, should continue to go to NCI.
One last question. What about vaccination data?
Right now, we do have a little over 600,000 data, 600,000 people and their vaccination data. Joel, we had started conversations with CVS, but honestly, those have just kind of fallen by the wayside. But we can readdress that in the future. I know that that's a pain point. We're looking for places that are pain points right away, and we thought the CMS and mortality were, for the reason that Andrew, Michelle, and Hythem talked about, were a high priority right now. So that's
fantastic that they're moving so quickly on PPRL in general. So it looks like it's really quite usable. That's fantastic. That's really fast, actually. So great. Well, this is fantastic. So we've got just a few more minutes. Any other questions or thoughts?
Well, one thing I just wanted to say, I'm sorry I'm yammering so much, is that what Andrew and Hythem and Michelle did, everybody, was really wonderful. This is for in-hospital acute, and I think we need to do best practices for other domains. You could imagine we need to do it for, is it prophylactic? Is it help with recovery? So I just wanted to say that I think there's a lot of opportunity to raise all boats, and I just want to thank everybody on both teams for their work, and I think this will help the whole community. So I just thank you, everybody.
Thank you, Ken, for bringing that up. I will say the reason we started with in-hospital acute, it is the the best chance of being able to capture enough of the information needed to be able to look at drug effects in a rigorous way. So I'm more optimistic that we will be able to look at drug effects for prevention or sort of long-term recovery once the claims data are pulled in. Right now, the One Health System EHR limited view is going to make it really tough to look at things that are happening outside of an in-hospital setting. So again, kudos to those who are bringing in the link data, because I think that is going to be one of the paths that get us to being able to think about out of hospital care and what patient trajectories look like there.
Yeah, no, absolutely. Have you seen, what do you see as the relative role of linkage across health systems for patients who are going back and forth? The Duke and UNC is frequently
Our classic.
Yeah, right. Have you had any further thoughts or experiences along those lines?
That's a really great question. I know that there are, there are hashing methods that have been developed to do exactly that dedupe work across institutions. PCORnet has developed some of that. I don't know how much of it is in place at this point. I'm again with the claims data, I actually think that might reduce some of the worry about that, because we would be able to see from the claims side at least the totality of the healthcare encounters, and then would have a deeper sort of clinical drill down for individual encounters that happen to be represented in the EHR as well. So in an ideal universe, I'd love to see sort of the full picture of patients, regardless of which health system they happen to be in. But if I had to pick one problem to solve, I'd rather solve the claim side of the puzzle, linking that onto the EHR, than to be focused on deduping people who are seen across health systems initially.
Great. Yeah, I mean, Ken, I'm sure can elaborate, but certainly dedupe has been one of the PPRL use cases, with or without additional data sources.
And Soko's point in the chat is really apt, that bringing in claims data only gets us so far, because we are still stuck with a very fragmented payer system, and so we'll probably do a pretty good job of being able to know what the story is with people who have Medicare, maybe Medicaid. But for a lot of the other types of insured populations out there, we won't probably be able to bring those data. And then, of course, there are lots of uninsured individuals who will be not seen, and that's a whole nother problem.
Yeah. Well, this was great. So I think we're over time, but these were both great presentations, fantastic progress, and want to thank everybody. This was a really excellent session, as these have been. Have a good week. Take care.
Thank you.